Okay, welcome to the deep dive. Today we're getting into something really central to psychology and, let's be honest, to everyday life. Stress.
Hmm.
We all feel it, don't we? That sense of pressure, maybe being pulled in too many directions. But, like, how do we go beyond just feeling stressed to really, understanding it
Right. Measuring it, seeing how it actually affects us.
and figuring out what genuinely helps manage it? So that's our mission today. We're digging into stress using a set of sources that you, our listeners, provided.
Yeah, material looking specifically at measurement, why people react so differently, and what the evidence says about managing stress.
And for you psychology students listening, this is really core stuff. These aren't just random facts. They're foundational concepts, research findings you'll definitely encounter again, health psych, clinical work, research. It's all connected.
Definitely. And what's good about these sources is they really treat stress as multi-level. You got the biology, the psychology, the social context.
Mm.
It's all in there. It is complex. But the aim today is to pull out the key insights.
Okay, let's start with the physical side then. Stress isn't just a feeling in your head, right? It shows up in the body. So how do these sources say we can actually, measure that objectively?
Yeah, this is super important. It gets us past just asking someone, how stressed are you?
Mm-hmm.
Which, could be pretty subjective. The body's stress response, the whole fight or flight mechanism, leaves measurable biological footprints.
Okay, like heart rate. That feels pretty direct.
Absolutely. When you're stressed, your sympathetic nervous system gets activated, tells your heart to beat faster, pump more blood and oxygen around.
So tracking that.
Exactly. Measuring heart rate, especially if you can monitor it continuously and compare it to someone's normal resting baseline, gives you real-time data on that physiological arousal.
And the sourcers mentioned that even a high heart rate when you're supposedly resting can be a flag for psychological stress.
Precisely. It can be a really telling clinical indicator of chronic underlying stress.
Then there's blood pressure.
Chronic stress can cause blood vessels to constrict, making the heart work harder, and that leads to higher blood pressure over time.
Measured with the usual cuff.
Yep, the standard method.
Oh, Phil.
But, and this is key in the sources, for assessing chronic stress, you really need multiple readings over time, not just a one-off.
Okay, because one high reading could just be situational.
Exactly. Sustained high blood pressure, though, potentially driven by stress, has major health consequences, links to heart disease, stroke, serious stuff.
Makes sense. And then, of course, the stress hormones we hear so much about.
Right, the big ones. Cortisol is probably the most famous, the stress hormone. It's released by the adrenal glands, impacts the metabolism, mood, lots of things.
And the others, adrenaline.
Adrenaline or epinephrine, and also noradrenaline. They're more about the immediate, rapid response, that jolts that gets your heart pounding, blood pressure up, makes you feel alert.
Okay, and measuring those. The sources mentioned a few ways.
Yeah, you can measure them in blood for like an immediate snapshot.
Yeah.
Urine analysis can show hormone byproducts, giving a picture over a longer period. And saliva testing, especially for cortisol, is less invasive and seems to reflect the levels that are actually active in the body.
Interesting. Okay, so heart rate, blood pressure, hormones. What about skin conductance response, or SCR? That sounds a bit less intuitive.
Well, it basically taps into how much you're sweating, particularly on your hands and feet, which have a high concentration of sweat glands involved in emotional responses.
Ah, okay. Stress sweat.
Kinda, yeah.
Yeah.
Stress activates these sweat glands. Sweat contains salts, electrolytes, which makes the skin conduct electricity slightly better.
So you measure that connectivity.
Exactly. Small electrodes on the fingers usually. It's non-invasive, gives you a real-time read on your autonomic nervous system arousal, a direct indicator of your stress response happening right now.
And you mentioned earlier the sources link this real-time aspect to things like biofeedback.
Right, which we'll definitely circle back to. So just to wrap up this measurement piece, why is it so vital for psychology to have these objective measures?
Good question.
Well, it provides data that's independent of someone's self-perception or memory, which can be flawed. It gives concrete biological evidence of the stress load the body is under, essential for diagnosis, for tracking if interventions are working, and crucially for you students, for the kind of rigorous research you'll be reading and maybe even conducting. It's the physical proof.
Yeah, physical proof. I like that. Okay, so stress has these measurable physical effects, but the sources quickly pivot to something equally important. It's not just what happens, it's also about who you are.
Yeah.
This is where it gets really interesting, I think.
hmm
People react so differently to the exact same event. What did the sources say about personality factors and vulnerability to stress?
Yeah, this is classic psychology territory. The sources highlighted how certain enduring personality patterns can make people more susceptible to stress or even kind of lead them to create more stressful situations for themselves.
And the classic example that came up in the materials you provided is the type A personality, right? From that big Friedman and Rosenman study on heart disease back in the 70s.
That's the one. A major longitudinal study they followed, I think it was over 3,000 men for years, and found this really striking connection between a specific behavioral pattern they called type A and coronary heart disease.
And what defined type A, the sources describe them as like hyper competitive, always feeling rushed, impatient.
Exactly. Competitive drive, chronic sense of time urgency, often easily aroused hostility or aggression, trying to do multiple things at once, really striving, but in a tense way.
And the finding was pretty stark, wasn't it?
It was. Something like 70% of the men who developed heart disease during the study were classified as type A. It wasn't just that they experienced stress, their whole style seemed to generate it or amplify it.
Wow.
And importantly, the sources also note that later research kind of refined this, suggesting that the hostility component of type A seems to be the most toxic element, the part most strongly linked to health problems.
Okay, so not just being driven, but being aggressively driven. And type B is the contrast.
Pretty much the opposite. More relaxed, patient, less competitive, more easygoing, comfortable with taking things slower. And the sources indicate they generally report lower stress levels and have lower rates of stress-related illnesses. More resilient, perhaps.
Then there was type C as well.
Yeah, introduced a bit later by Timoshok. The sources describe type C individuals as tending to be very cooperative, patient, passive, someone who avoids conflict, and crucially, tends to suppress negative emotions, especially anger. They're often people pleasers.
And the potential health links there. The sources mention things like immune suppression.
Yes, there's been research, though sometimes debated, linking that pattern of emotional suppression to potentially poorer immune function, maybe higher risks for depression, anxiety, and even associations in some studies with certain cancer outcomes, although that's complex.
Right. But it's important, as the sources pointed out, to be critical of these neat boxes, isn't it? These typologies can be a bit simplistic.
Absolutely. That's a key evaluation point for psych students. They're criticized for potentially overlooking the role of the specific situation, cultural differences, and just the sheer complexity of personality. People rarely fit perfectly into one box.
Good point. So if these types are maybe too broad, the sources also discussed a concept that seems more focused on protection or resilience, hardiness.
Exactly. Hardiness is presented not just as a lack of vulnerability, but as a cluster of personality traits that actively buffer stress and promote resilience. It's about how you approach challenges.
And it's got the three C's, right? Let's unpack those based on the sources.
Okay, first C is commitment. This isn't just sticking with things. It's a deep sense of involvement and purpose in what you're doing, your work, your relationships, your values. It's the opposite of feeling alienated or like things are meaningless.
Finding meaning, staying engaged, even when it's tough.
Precisely. The second C is control. This is the belief that you can generally influence the outcomes in your life, rather than feeling like a helpless victim of circumstance. It's tied to having an internal locus of control, feeling you have agency.
So being proactive, feeling like you can do something.
Yes. And the third C is challenge. This one's really interesting. Hardy individuals tend to view changes, difficulties, and stressors not primarily as threats, but as opportunities for growth and learning. They embrace novelty and see setbacks as, well, challenges to overcome.
Almost like a growth mindset towards stress itself.
You could definitely frame it that way. And the sources mention research that supports this idea, like that Maddie study during a big company downsizing.
Yeah, the telephone company example. A huge stressor for everyone involved.
Right. But the study found that while about 2/3 of the employees suffered significant health declines, about 1/3 actually thrived despite the stress. And the key difference, hardiness. Those with high levels of the three C's stayed healthier and even grew from the experience.
That's powerful. And the Kobasa study, too.
Also supportive. Studied male executives using a stress scale, the SRRS, and found that those scoring high on hardiness reported significantly fewer illnesses, even when they had high stress scores. Hardiness seemed to act as a buffer.
So how you view and engage with stress really matters. Although, again, the sources rightly add caveats. Herbasa's study was just male executives, relied on self-reports, and it's correlational.
Right. Can't definitively prove cause and effect from that design alone, but still the consistent finding is suggestive.
And the exciting implication, particularly for psychology, is that maybe hardiness isn't fixed. Maybe it's something that can be fostered or developed.
That's the hope, and a major focus for potential interventions.
Definitely. Okay, another layer of difference the sources explored, gender. Are there typical patterns in how men and women respond to stress?
The sources suggest, yes, there are on average some observable differences, but it's crucial to understand it's likely a complex interplay of biological factors, social learning, and maybe cognitive styles, not just one thing.
Biologically, that tend-to-befriend model came up.
Yes, proposed by Taylor and colleagues. It offers an alternative, particularly for females, to the classic fight or flight. The idea, from an evolutionary perspective, is that fighting or fleeing might be dangerous for offspring.
So instead, the response might be to tend protecting and nurturing offspring and befriend seeking social support from the group for mutual defense and help.
That's the core idea. And the sources connect this potentially to hormones.
Yeah.
Oxytocin, involved in bonding and affiliation, might be more central to the female stress response, possibly enhanced by estrogen, whereas testosterone, more dominant in males, might facilitate the more classic fight-or-flight reaction.
Interesting. And cardiovascularly, any typical differences mentioned?
Yeah, research often shows men exhibiting greater cardiovascular reactivity to stressors, bigger jumps in heart rate and blood pressure. This could be one factor contributing to gender differences in cardiovascular disease risk later in life.
Okay, so some biological possibilities. What about social factors? The sources mentioned the Brown and Harris study.
A landmark study, really. They interviewed hundreds of women in London about stressful life events and depression. A key finding was the powerful protective effect of social support.
How so?
Women who faced severe stressors but had at least one close, confiding relationship were significantly less likely to become depressed compared to women without such support. Having a close friend acted as a major buffer.
Huge implications for thinking about social networks and mental health.
Absolutely. And then there are cognitive factors or coping styles.
Right, the problem-focused versus emotion-focused distinction.
The sources highlight that, again, as a generalization, men are sometimes reported to lean more towards problem-focused coping, taking direct action, analyzing the problem, trying to change the situation.
Okay.
Whereas women are often reported to utilize more emotion-focused coping, managing the feelings associated with the stress, seeking emotional support, maybe reframing the situation to feel better about it.
And that Vogel study comparing students.
Yeah, that study looked at cardiovascular responses during stress tasks. It found male students showed greater reactivity, particularly when trying to suppress anger. It's just one study, student sample, potential cultural limits, but it adds another piece suggesting these different factors might interact.
So it's really painting a picture of a complex interaction, biology, social roles, learned ways of coping, all potentially contributing to some average gender differences in stress response. Not deterministic, but patterns.
Exactly. It reinforces that multi-layered perspective we started with. You can't just look at one piece in isolation.
Okay, makes sense. So we've looked at measuring stress, how personality and gender might play a role. Let's get to the really practical part. What can we actually do about stress? Your sources covered several different management approaches.
Yeah, they group them quite logically, actually.
Yeah.
You've got the biological approaches like medication, then behavioral or physiological methods like biofeedback, cognitive approaches focusing on thoughts, and social approaches leveraging support networks.
Let's start with the biological. Drug therapy. Benzodiazepines were mentioned.
Right. These are common anti-anxiety medications. They work primarily by enhancing the effect of GABA, which is the brain's main inhibitory neurotransmitter. Think of GABA as hitting the brakes on neuronal activity.
So they calm the system down.
Essentially, yes.
Yeah.
They reduce anxiety, promote relaxation, can help with sleep. The sources mentioned examples like diazepam, Valium, lorazepam, Ativan, alprazolam, Xanax.
And beta blockers, they work differently.
Totally different mechanism.
Interesting.
Beta blockers target the physical symptoms. They block the effects of adrenaline and noradrenaline at specific receptors, beta adrenergic receptors, on heart muscle and other tissues.
So they stop the pounding heart, the shake.
Exactly. They reduce heart rate, lower blood pressure, lessen tremors. They don't necessarily reduce the feeling of anxiety in the brain, but they block the physical manifestations. Often used for things like performance anxiety, stage fright, sometimes social phobia.
Okay. Now, a really critical point for psych students from the sources was about the limitations of drug therapies.
Absolutely crucial. The sources are clear. These drugs primarily manage symptoms. They don't typically address the root causes of the stress, the situation, the thinking patterns, the coping skills deficits.
So it's temporary relief.
Often, yes. And they come with significant downsides highlighted in the material. Risk of dependency, tolerance, needing more for the same effect, withdrawal symptoms if stopped abruptly, and side effects like drowsiness, dizziness, impaired coordination or memory. They can be very useful tools, especially short-term or for severe symptoms, but they're rarely the whole answer for ongoing stress.
Good to keep in mind. Okay, moving to a different approach. Biofeedback training. How does that work exactly?
The core idea behind biofeedback is learning conscious control over bodily processes that are normally automatic or unconscious. Things like heart rate, muscle tension, skin temperature, even brainwaves sometimes.
How do you learn that?
Through real-time feedback. You're hooked up to sensors that measure the physiological process, say, electrodes measuring muscle tension in your forehead for tension headaches. The machine gives you immediate feedback, maybe a tone that gets lower as you relax the muscle, or a visual display.
Ah, so you can directly see or hear the effect of trying to relax.
Precisely. You start with a baseline, then you're taught specific techniques, relaxation exercises, deep breathing, visualization. You practice these while watching the feedback, learning what works to change the signal in the desired direction. The goal is eventually to gain that control without needing the machine.
And the sources mention the Budzinski study on tension headaches as evidence.
Yeah, a classic study. They had groups of people with chronic tension headaches. One group got biofeedback specifically targeting forehead muscle tension plus relaxation training. Compared to control groups, just relaxation or no treatment, the biofeedback group showed significant reductions in headache frequency and intensity and used less medication. It showed people could learn this physiological control.
So advantages are things like no drug side effects, learning a skill.
Exactly. It empowers the individual, teaches a self-regulation skill that can be long-lasting with practice.
But limitations.
But it requires specialized, sometimes expensive, equipment. It takes time and commitment to learn. It might not directly address the underlying psychological triggers or thoughts driving the stress. And, like most therapies, effectiveness varies from person to person.
Right. Okay, let's shift to the cognitive side. Stress inoculation therapy, SIT. Developed by Donald Meichenbaum. The name itself sounds protective.
That's exactly the metaphor. Like a medical vaccine inoculates you against the disease by exposing you to a weakened form. SIT aims to inoculate you against future stressors by exposing you to milder stressors in a controlled way while teaching you coping skills, building psychological resilience.
And the sources outlined 3 phases. What's the first one? Conceptualization.
This is really about education and understanding, helping the client understand the nature of stress, how their own stress response works, what triggers it, what thoughts and feelings come up, what behaviors result. It involves assessment, identifying problems, and challenging existing unhelpful ways of thinking about stress. It's laying the groundwork.
Okay, understanding the problem. Phase 2 is skill acquisition and rehearsal.
This is the toolbox phase. Clients actively learn and practice a range of coping skills tailored to their needs. This could be cognitive skills like identifying and challenging negative automatic thoughts, cognitive restructuring, practical skills like problem solving or time management, behavioral skills like relaxation techniques, or communication skills like assertiveness.
And they practice these.
Oh yeah, in session, through role-playing, maybe using imagery, and then as homework assignments between sessions. Repetition and practice are key.
Got it. Then phase 3, application and follow-through.
This is where the rubber meets the road. Clients start applying the skills they've learned to real-life situations, often starting with less intense stressors and gradually working up. It involves planning for stressful situations, practicing coping strategies in vivo, and importantly, developing strategies for relapse prevention, how to handle setbacks and maintain the skills long-term.
The sources seem pretty positive about SIT's evaluation. Comprehensive, flexible.
Yes, its strengths are that it's very comprehensive, can be adapted to different problems and populations, has strong research support, and focuses on building lasting skills.
But limitations.
It definitely requires significant client motivation and effort. It's an active therapy. It can be quite time-intensive. It might not be the first choice for someone in acute crisis or with very severe mental health conditions without modification. And, like many therapies, it really relies on a skilled therapist to guide the process effectively. Needs cultural adaptation sometimes, too.
Makes sense. It sounds powerful but demanding.
Okay, last major category from the sources, social support interventions. We touched on social support earlier, but how is it used as a direct intervention?
Well, recognizing its power as a buffer, interventions can focus on assessing and strengthening an individual's social support network. It's about leveraging those connections.
And the sources broke down different types of support
Sure.
based on Schaefer and colleagues.
Right. They identified a few key types. First, instrumental support. This is tangible, practical help, lending money, giving someone a ride, helping with chores or childcare, concrete assistance.
Okay.
Second, emotional support. This is about expressing care, empathy, concern, listening, providing comfort and reassurance, making someone feel understood and valued. And third, esteem support, sometimes called appraisal support. This involves providing information or feedback that helps someone reappraise a situation or bolsters their self-esteem and coping abilities, affirming their strengths.
And that Waxler-Morrison study on breast cancer patients really highlighted the impact. A very powerful example cited in your sources, yes. They looked at women diagnosed with breast cancer and assessed their social networks, friends, family, community ties. They found that women with stronger social networks had significantly better survival rates over the course of the study.
Wow, better survival rates.
Yes. And a key finding was that it wasn't just about the number of contacts, but the quality. Having close, confiding relationships, people they could really talk to and rely on, seemed particularly important.
That's incredible, but again, nuance is needed, right? The sources warned that social support isn't always positive.
Correct. Sometimes receiving too much support, or the wrong kind, can make people feel like a burden or guilty, or it can undermine their sense of competence. This is sometimes called support burden.
Or getting unhelpful advice.
Exactly. Or maybe support that encourages unhealthy coping, like just complaining without problem solving. So while generally hugely beneficial, the type and delivery of support matter. It's not a magic bullet.
Okay, so pulling all these threads together from the sources, what's the big picture on stress for our psychology students listening? It's clearly complex, biological, psychological, social dimensions all interacting.
Absolutely. Understanding stress means looking at how we measure it objectively, appreciating the vast individual differences in how people react based on personality or maybe even gender patterns, and knowing there's a whole toolkit of management strategies.
And the key takeaways for effective management seem to be.
Well, based on the sources you provided, first, accurate assessment is vital, probably using multiple methods, not just self-report. Second, interventions need to be personalized. What works for one person might not work for another. Third, the focus should often be on skill development. Things like SIT or biofeedback teach lasting resources. And fourth, don't underestimate social integration. Leveraging support networks is critical, while also being mindful of potential downsides.
For you listeners, really think about how these concepts interconnect. How does, say, someone's hardiness profile influence which stress management technique might be most effective for them? How do biological predispositions interact with learned coping skills taught in therapy? How might social support buffer the effects of chronic physiological stress activation we talked about earlier? These aren't isolated topics. They weave together throughout psychology.
This deep dive, drawing from your source material, gives a solid foundation, but the field keeps moving. So a final thought, maybe a question for you to carry forward from these sources. How will emerging technologies, maybe advances in neuroscience, mapping stress pathways, or digital health tools for real-time monitoring and intervention? How might these revolutionize our understanding and management of stress in the coming years? What new questions will arise about that intricate dance between our genes, our environment, our thoughts, and our stress responses?
That's a great place to leave it. Lots to think about. We really hope this exploration of your sources has been helpful and sparked some connections for your own studies. Keep digging deeper.